Scot Hutchison. Hello, it's Dr. Scot Hutchison, and here at Reproductive Health Center in Tucson, Arizona, and it's our first Hutchison's Huddle for the new year. So we moved it up a little bit because we see that most of you watch these later in time anyway, on your own time. So that kept me from having to keep my coworkers here super late. And I thank Karina Bakame today, who is here helping facilitate this live streaming. So today's topic is about what to expect as you start fertility evaluation. And so I won't speak for all other fertility practices, but I'm just going to tell you kind of what you would expect as far as evaluation. And let's first start with when you should actually be evaluated. And that's after you have been trying to get pregnant for about a year, if you are under age 35, and if you are over age 35 after about 6 months of attempts, or with either one of those, if there's some problem that you know has probably a pretty good possibility of interfering with conception, like no periods at all, or very irregular periods, or a male partner with a history of a testicular injury, or if you have know that if you're lesbian couple, gay couple, and there is no chance of getting pregnant on your own, then call and make the appointment sooner. So typically, for both the male and the female partners, if they're in a heterosexual relationship, we want them both to be toeing the line as far as no alcohol, no recreational drugs. Again, just because it's legal doesn't mean you should do it, because marijuana has been shown to be fairly corrosive for fertility. Likewise, I don't like people to have CBD oil on board, because a lot of the CBD products are contaminated with THC. So I would avoid all that. We like you to be taking vitamins, like a men's multi if you're a guy, if a prenatal if you're a woman, for at least 3 to 6 months before even attempting conception if possible. Extra folic acid if you were wanting to get pregnant and right away and you haven't been taking the prenatals for at least 3 months, to really help decrease the risk of birth defects in the brain and spinal cord. And then for women who are either single and going to be doing donor insemination, or lesbian couples that are going to be going a route where one is going to be trying to get pregnant with the other one's eggs, or just with donor sperm, we really like you to, again, follow those rules. For gay male couples who are going to be using egg donation and gestational carriers, we'll also like whoever is going to be providing the sperm to also toe the line with that. And I think that it's probably easiest if both partners do that, because it's pretty difficult, I think, to abstain from things like really nice wine if your partner's sitting across the table from you saying, "Oh, this is so good with this dinner." So anyway, so that's kind of the timeline, like when you should call on things. Typically, when people call here, we like to have we set up for at least a 45-minute appointment. Most of the time, it's going to go beyond that. Sometimes it'll go under. A few people this week, actually, we were able to kind of wrap things up in about 40 minutes because they had sent in their history forms beforehand, and we were able to take a look at that and do all the data entry for that, and kind of streamline taking their history. And they were very uncomplicated, so they didn't have lots of issues for us to have to cover after the physical exam. But typically, we take about 10 to 15 minutes to kind of complete the whole history and figure out what's really going on. And then we take about 10 or 15 minutes to do a physical exam and a pelvic ultrasound. And that is usually a pretty quick deal and not too uncomfortable, but kind of like having a pap smear. We usually will do gonorrhea, chlamydia cultures or DNA probes, and then by manual exam to see if anything if we can feel the nodularity from endometriosis or fibroids. and see if things feel like they're stuck together in the pelvis, suggestive of adhesive disease, and then a transvaginal ultrasound. But that all goes pretty fast, and it doesn't really matter if you're actually menstruating or not with that. We don't care. I mean, everybody always feels self-conscious themselves if they're bleeding, but again, we here don't care about that at all. And sometimes that's a good time to do a physical exam, because it's sort of a clean slate, so to speak, in the pelvis with regard to ovarian cysts and things like that. Sometimes when we find things, especially on the pelvic ultrasound, like fibroids or ovarian endometriosis cysts, we will take the time to measure those and then catalog them to try to get a record of kind of what is going on right now. And sometimes that can be pretty tedious. So if somebody has multiple uterine fibroids and then like an endometrioma cyst or two, that transvaginal ultrasound can kind of stretch into several minutes rather than being really pretty quick. Then we usually will regroup in the office, and we'll talk about what we found, what else evaluation we're going to do. And typically, if you haven't had a lot of blood testing already, what we do is have you on cycle day 2 or 3, or day 2 or 3 of normal period, to get anti-Mullerian hormone testing, follicle stimulating hormone, luteinizing hormone, to look at the ratio of those two, which can kind of suggest some ovulatory dysfunction, estradiol, red cell antibody screen, prolactin, thyroid testing, chem panel, blood counts, and then check for all the serum bad diseases, so HIV, Hep B, Hep C, and syphilis. And then we'll also do a test of the fallopian tubes in women who are actually going to be trying to get pregnant with the fallopian tubes. And that's called a hysterosalpingogram. And that's done with the ultrasound has no radiation, that's just sound waves. The histogram actually uses a little bit of X-ray, which is ionizing radiation, to see the fallopian tubes. But that still is the gold standard for assessing the fallopian tubes short of surgery. So we will go ahead and do that test as well. That's done after the menstrual period, but before you ovulate. And the reason for that is that eggs are pretty radio resistant, and so are sperm, but in early embryos, that's a lot of genetic material that's being unfurled and being used, and so it's more susceptible to that ionizing radiation. So we don't like to do that after you may have actually ovulated and conceived. For women where there's no chance of getting pregnant on that given cycle, we will do those sometimes later that in the cycle if the uterine lining doesn't look too thick. But if it's really pretty thick, in the second part of the cycle, you can actually cause the fallopian tubes to be artificially kind of obstructed by the lining being really thick or getting debris into the close-in parts or proximal ends of the fallopian tube. So, and that's the standard fertility evaluation. And then we also do a semen analysis. So semen analysis has been done about the same way for about the last 100 years or so. Interestingly, the average numbers of sperm in semen analysis have fallen by about 5-fold over the last 100 years. And it's hard to know what that is all being caused by, but it's probably a combination of factors, including environmental pollution. And then especially some of the agents that can act as hormones in the body, like the plasticizers like BPA and its ilk. Those appear to do some really bad things for sperm production. Also, people have gotten heavier over time. As men gain more fat mass, they make more estrogen, and that will pull sperm counts down and the sperm motility. So semen analysis, though, we typically like the sample to be at the office within about an hour. We prefer that men produce a sample at home because it's a little more private, and they're able to usually give a little bit better sample. The volume of the seminal fluid is relatively dependent on length of abstinence time. So the longer, the more volume you have, but also arousal. And so if you're really nervous and you're trying to collect in a restroom, then that doesn't really give you the best volume that you typically are going to have. We like guys to get the best sample to ejaculate every day for about 3 or 4 days beforehand, and then take a day or two off, and then take their time collecting the sample at home, and then just bring that in. For guys that are farther away than an hour, we typically will provide them a place to collect on site where they can be behind a couple of closed doors. So that's the general evaluation. What we tend to see in terms of what's keeping people from getting pregnant, at least a third or more of folks have some sort of ovulation problem, and those are pretty easily corrected. A lot of people have endometriosis or some history of pelvic adhesive disease, and then about 40% or to 50% have some degree of male partner contribution to that, either with lower sperm counts. Also, guys who are over 40 tend to have sperm that work less well, and the risk of having kids with autism and bipolar disorder is a little higher for guys over 40 just because of those genetic problems. The general rule of thumb with making an appointment, a lot of people feel kind of uncomfortable asking questions. We really want you to ask those questions. We really want to know, if you're really understanding the whole process of like what we're trying to figure out what's going on. And then if you really understand like whatever treatment we're going to have you do, because understanding that biology is really pretty important. In other places, in our neighboring state of New Mexico, they have far better health education in high school years, even in middle school years. Here in Arizona, we have really abysmal health education. Part of it is due to a kind of agenda by some legislators up in the Maricopa County or Phoenix area to really restrict the sex education, because basically they don't feel that it's appropriate for even high school students to have access to that information. But the upshot is that it's not just about talking about sex education and birth control, but just biology. So many of our patients don't understand, even the basics of ovarian function, like how the ovary is recruiting several eggs a month, and then it'll allow one to go forward and ovulate, and that container for the egg is called a follicle, and that after that follicle releases the egg, it's going to make progesterone, and then that will continue until the woman gets pregnant or until a couple of weeks go by. And then if she's not pregnant, then the ovulation cyst will undergo programmed cell death and kind of go away, and then the woman will get a menstrual period. So if you don't understand all that stuff, please let us know, because we really want to bring you up to speed on that so that you can have a pretty good idea about the rationale of what we're going to try to do to help you conceive. Karina, anything else you can think of? So the people where we find things, she has some questions. The people where we find things wrong, like even on the initial evaluation, like if they've got uterine lining polyps, sometimes we will evaluate those further by doing what's called the sonohysterogram test, or the hysterosalpingogram, where we're checking the fallopian tubes as well. And a lot of those polyps will go away with proper nutrition. You probably have heard me say before, but there's a growing body of data that the uterine lining biome, or the bacteria that live in the uterine cavity, actually have a big impact on our fertility. So to get those really good bacteria into the uterine cavity, what we are recommending is that people eat fermented foods regularly. So foods like kimchi and active culture sauerkraut and active culture pickles, and eat at least 2 or 3 bites of those with some other food once a day, or even a few times a day. If you're new to those fermented foods, sometimes they will give you a little bit of diarrhea. I would encourage you to stick with it and continue with those until things straighten out. Certainly our patients who have a history of chronic constipation will do a lot better typically with eating those fermented foods. And we really do want people to have regular bowel movements all the way through pregnancy, because pregnancy tends to slow down the bowels anyway, and it can really put people at risk for things like hemorrhoids, which are really uncomfortable later. So if you do have polyps that don't go away on their own, we usually will remove those with a tool called a hysteroscope, and that's a telescope that goes in the uterine cavity. And then we can use different tools like the MyoSure device, which is a small suction and cutting device that can then chip those little polyps out of there. People who have really high sugar diets, high junk food diets, tend to have more uterine lining polyps. And what we see is that they tend to have a harder time getting pregnant overall. Part of that may be that a high junk food diet also puts people at risk for being heavier, and if you're heavier, your fertility is lower, whether you're male or female. Typically, we'll have discussions with people about what our findings are down the road, or if they're confused. The IVF discussions, in particular, we do those without charge because we don't want people to feel like they have to commit to IVF and pay out of pocket to kind of figure out more about that. So if you would like to have one of those discussions, if you're thinking about IVF, certainly that's a really good idea to get that going sooner rather than later. Anyway, if any of you have any questions right now, feel free to ask. But that's kind of how we get started here at Reproductive Health Center. But other places may do it a little bit differently, and feel free to send us messages asking questions if you have any others. Oh wait, there's another question here. What about tubal reversal information? So for those of you who've had a tubal sterilization procedure, and this traditionally has been removing a segment of the fallopian tube, and then the tube is tied, or it can be, or just the center part of the tube can be burned. Those can be reversed with microsurgery. In general, the pregnancy rates for tubal reversal surgery are less than they are with IVF now, because the technology with IVF has gotten so much better that in terms of cost effectiveness, as far as dollars spent for baby got, the IVF is probably more cost effective in most areas of the country. However, there's still people who want to have tubal reversal surgeries. Those we typically will do, for those patients, we'll typically do that hysterosalpingogram test to see how much remaining tube is left close into the uterus. If there's not a fairly good amount of that left in there, then trying to do the connection with the other part of the tube usually is a dismal failure. And most of those surgeries, we will actually start with doing a laparoscopy if we feel like there's a good chance of it working. And then if there's a fair amount of tube left, then we'll go ahead and put the tubes back together. That procedure, we typically will quote people that the tubes will usually stay open, and then about 50% of the time they'll take home another baby. The disturbing thing about tubal reversals is that about 15% of the patients will have a pregnancy in the fallopian tube down the road, and those can be life-threatening. So we like to, whenever people conceive pretty quick, after a tubal reversal, we like to figure out pretty quickly where the pregnancy is. And if it's in the fallopian tube, then it needs to either be removed surgically, or we need to give some medicine called methotrexate to have the pregnancy go away. Because you can't open up the tube and transplant the pregnancy into the uterus, unfortunately. The same things apply for people who are going to go through tubal reversal, as far as both parties, taking their vitamins, eating really healthy food, getting enough sleep, not eating junk food, staying out of hot tubs. Certainly, we want to do a semen analysis before we would commit anybody to tubal surgery, because we really need to know if there's going to be enough sperm, and you really need to have a pretty normal semen analysis to have the best pregnancy rates with tubal reversal surgery if you're just going to have intercourse for conception. So what else about tubal? Oh, a lot of patients in the future aren't going to be eligible for tubal surgery because a few years ago, the gynecologic oncology doctors found out that a lot of what are thought to be ovarian cancers actually originate in the fallopian tubes. So it may be as high as 60% of the ovarian cancers may be from the tube. Certainly, it seems like a pretty solid number is about 40%. So when women are declaring that they're not going to have any more kids in the future and they want really good contraception, then the surgeons who are doing the tubal sterilizations, a lot of the time now are removing the entire fallopian tube just to decrease that risk of ovarian cancer in the future. And certainly if you remove the whole tube, then there's not going to be anything to put back together, and you've got to do IVF for conception. So, but it's good to look into both of those options, both IVF and tubal reversal surgery if you're wanting to have more kids after tubal sterilization. A phenomenon that we tend to see all the time is that women who've had tubal sterilizations typically did them for a really good reason, like they didn't tolerate some or many forms of other contraception. So they have gotten pregnant lots of times accidentally on another contraceptive, for example. So they consider themselves to be very, very fertile. But once those tubes have been damaged and then some time has gone by, then the odds of getting pregnant can really shift into not so good a number. So the kind of the rule of thumb is if you've had a tubal ligation for longer than 10 years, you really need to think twice about doing it, just because you probably, you're 10 years older, and if you had it in your 20s, you're now in your 30s, maybe your late 30s or early 40s. And even though you had great fertility a long time ago, it really may not be all that great now. And with tubal reversal surgery, you cannot test embryos. You're going to ovulate whatever egg you ovulate, and it's going to roll into the uterine cavity and implant. And we know that starting at about age, even in the late 30s, the risk of miscarriage due to abnormal genetics in embryos tends to go up. By the time you're 40, it's about, give or take, 20% or more. By the time you're 42, it's about, 34 to 50%. I mean, it just keeps kind of climbing as time goes by. And that's because most of those embryos are abnormal. So for women in their later 30s or early 40s who've had tubal reversals or have had tubal sterilization surgeries, IVF is really probably a better choice for family building, because you can test those embryos before you put them in to decrease the risk of miscarriage and increase the chances of actually taking a baby home. So anyway, if you have other questions, give us a call here in Tucson, 520-733-0083. And even if you're outside of our area, give us a call. We do these information sessions for a reason, and we want people to be well educated. And especially that do yourself a favor and don't eat junk food and eat those pickled vegetables, those fermented foods, because those are going to do you a good turn. So with that, I don't see any other questions or anything. You all have a great night.